Hey, we're the Turd Nerds. We're glad you're here. Before we take the plunge, let us introduce ourselves. I'm Dr. Rebecca Sand, a naturopathic physician and licensed acupuncturist specializing in digestive, microbiome, and hormone conditions and integrative fertility.
I'm Dr. Ami Kapadia. I'm a medical doctor trained in family medicine and functional medicine with a special interest in combining standard therapies with lifestyle and nutrition-based interventions.
And I'm Dr. Alana Gurvich, a naturopathic physician, licensed acupuncturist, and a fellow of the American Board of Naturopathic Gastroenterology. I specialize in IBD, IBS, and other functional GI disorders. Let's dive in.
The following discussion is for educational purposes only and not intended to diagnose or treat any diseases or conditions. Please consult your doctor before incorporating any of this information into your care. The information presented on this podcast is not medical advice.
Welcome back. We are thrilled to also be welcoming back our one and only Dr. Ami Kapadia, who is finally back completing our turd triad. She has a really interesting case. I mean, all your cases are pretty good, but a really interesting case on diarrhea.
Yes.
Amazing.
We never have patients with diarrhea.
Well, we usually talk about constipation.
It's harder to treat.
Well, I don't know. We'll see about this case.
They can both be hard. Okay, so I have a patient, female patient. I was recently listening in one of my parents' doctor's appointments, and the doctor said she likes to use the word experienced for her more experienced patients. She goes slower with medications, and it was very funny. Anyway, she seemed great. So whenever we do cases, as you know, we just, for privacy reasons, we change various things, and it's kind of like a conglomerate of different situations, but still with the main pieces for our learning. So I'm going to be talking about middle-aged to experienced female.
Love that.
Who's had diarrhea for close to a decade at least.
Can I just say, as someone who was recently a geriatric pregnancy, experienced
you were? No.
both of my pregnancies.
Oh, really?
And then they changed it. Epic changed it to elderly.
Wow,
So
elderly pregnancy?
Elderly. Yeah, I saw that.
We used to just call it advanced maternal age.
Yeah, that's a little better. Well, we know what you're getting at, but experienced.
Yeah, it's very nice. She was a very nice lady.
Anyway, I like this term.
Anyway,
okay, so an experienced
female. She's had diarrhea for at least a decade. She was diagnosed with collagenous colitis, which I feel like Alana explains better than me. Like, can you just review the whole
microscopic colitis thing? Yeah. Okay, microscopic colitis basically is the only symptom that you're looking for is diarrhea. It is non-painful, non-bloody, non-formed bowel movements. What happens is when they go in grossly on colonoscopy, when they're scoping, the tissue looks completely normal, right? But then they take biopsies. This is very important. This is why you can't get a screening colonoscopy.
Because they won't do the biopsies.
Because they won't do the biopsies. Yeah. You need a diagnostic colonoscopy, which is more expensive. Yeah. But they take the biopsies, and under the microscope, they can see microscopic inflammation. There's lymphocytic or collagenous. Collagenous has more anatomical changes and is more progressed than lymphocytic. So she was obviously, because of her experience and her age, she had more changes in her intestine.
Does that mean she probably had it longer? Like
yes.
People, so it's progressive.
Yeah.
Okay, so is it always lymphocytic first, but we just might not catch it at that stage, or?
My answer is I think so, and I'm not positive, but I think so.
So wait, one question I have about this is how often does it turn into frank inflammation, like that you could just see like IBDs? Not
super often. So the other thing the other bucket to look at is there's the bucket of IBS, and then there's the bucket of IBD. Yep. Microscopic colitis is actually its own bucket. Okay. It's not an IBS. They think there's a little bit maybe of a partial autoimmune component. Yeah. There's definitely microbiome changes component, but it's not, it doesn't fit into any of the other two buckets.
Is that maybe why it gets missed so often, or is it just really the scope?
I think both things. I think that they have to look for it. I cannot tell you how many patients I sent where I put the referral to scope to rule out, and still the gastro did a screening.
Maybe you have to send them with a letter.
I did.
Okay. To show the doctor on the day of the colonoscopy?
Yeah, I mean, I guess I haven't done that.
You could have them write it on their
Yeah, that's what I say to my patients, like, as you're going under, just say biopsy.
Because it's a bummer to do a prep, to go under anesthesia, especially if you're experienced in age, and then have them not take biopsies.
Yeah.
And this is like a newer diagnosis since when we trained like 20 years ago.
It's
probably because of all the meds we have people on. But anyway, we'll talk about that later.
Spoiler.
Because I didn't learn about this in my training.
I don't think I did either.
Okay.
Did you?
I don't think so.
I feel like when I trained you, it was like just coming to my attention.
Okay.
Well, that sounds about right.
Glad to see that she had had.
Wait. You're right, because I kept calling it mucilaginous colitis.
Yes.
And you kept correcting me.
Yeah. I trained Dr. Sand a very long time ago.
Oh, yeah. It was a while.
Okay, so back to the case. I was glad that she actually did have biopsies and it was diagnosed like several years ago. The challenge was it was controlled for several years and then she was having a flare the past year or so. She was seeing the specialist and they did all the routine testing and wasn't too high. It was like a little bit over 100.
Let me stop you there.
Okay.
With microscopic colitis, calprotectins do not routinely get elevated.
Yep.
The things that elevate calprotectins, which is basically a white blood cell sample in the intestine, are colorectal cancer, inflammatory bowel disease, and infections.
Losis.
Colitis, not losis.
Not the osis.
Yes.
And you said it can get diluted if it's more proximal in the colon.
So basically, you expect to see these raging high numbers with like proctitis, but if you're getting a sample that's all throughout the colon, you might not get as much potency in there as
So
if
it
it's
depends
sitting.
on the
Because
sample.
it's actually released by cells that are being drawn to the area of inflammation. So if it's further up, it gets diluted as it goes down the colon.
Yes.
So the closer it is to the opening,
Yeah.
the more you're going to see.
Okay.
But I mean, we do see calprotectin elevated in microscopic colitis. It's just not a reliable marker.
Exactly. It's
for
not
it.
reliable. Yeah.
Yeah. Elastase was fine.
Okay, why do we care about the elastase?
This case is going to take a long
Because
time.
of inflammation. So if people are not absorbing
Just for a second.
And so
Right.
we're trying to rule out non-inflammation.
but the causes of it, I was thinking causes
Oh
of
yeah,
inflammation.
we're trying to rule out pancreatic insufficiency because
Yeah.
that also can cause this type of presentation.
Have you had patients who have pancreatic insufficiency plus
Yes.
microscopic colitis?
Yes, but the
Okay.
problem is, again, it's not a reliable
Yeah,
marker
yeah,
because
yeah.
everything's getting
But we
diluted.
don't do the test that we
Right.
would need to do for. So we used pancreatic elastase for that to get a general idea. That was okay. A pathogen panel was fine. It had been run maybe 3 times in the last year or so since this flare started.
And do you know if it was an O&P or a PCR?
It was a PCR.
Okay.
Which we still never are quite sure if we would catch everything, but
it's
pretty
better than
good.
an NP.
Right.
yeah. And then C. diff was negative. Blood work was all normal, which is pretty standard with microscopic colitis.
Yes.
No recent antibiotic. She had been on budesonide, and it wasn't helping.
And that's like the first line, right? So for
Right.
microscopic colitis, we start steroids, gut-focused steroids.
Yeah.
It didn't do anything.
It did work in the past, but it was
Okay.
not working for this flare. They had actually tested their water at home and it was fine, and no one else in the family was sick. Basically, they just saw GI. They weren't getting better, so I was seeing them for a regular visit, and we couldn't really figure out what else might be going on.
Did they try mesalamine or any other drugs?
They did not try mesalamine. They
Pepto.
tried loperamide, psyllium, prednisone, budesonide, all of those, and none of those were working this flare.
So I have a question about Pepto-Bismol because I've seen GIs put people
And I have some info on bismuth later, but
well,
yeah.
bismuth, but also the salicylate.
Yeah.
Because that can
okay.
actually aggravate certain gut issues, and especially people who have salicylate sensitivities.
Yeah.
So, I mean, should we be giving that to? I mean, short term, maybe, but
It is not.
It's probably better,
No, they do different things.
right?
You know,
to
and-
just stop the diarrhea in the short term.
Yes.
What about
and
plain
no.
bismuth though? Because that actually
like
we'll
plain
talk about
bismuth.
later.
Yeah.
But you're saying they probably just give Pepto because it's easier. To
Yeah,
Right.
Pepto's just
prescribe.
available, but it also
Exactly.
has red number 40 and blue number, all of that, and
Yeah.
it's a preservative. It's like
Yeah.
chock full
Yeah.
of preservatives.
Yeah.
So I don't love it, but it's also a good tester.
Okay. So and I would assume you could get secondary. Can you get secondary lactose intolerance from microscopic colitis, or would that have to
Not
affect
usually
the
because
small
that's a
intestine?
small bowel. Yeah.
So we still tried.
But what I have learned
Uh-huh.
in doing a very deep dive into casein A1 and casein A2, because this is like one of my favorite
Yeah.
Okay.
plans for people. So people can have lactose intolerance induced by inflammation.
Uh-huh.
for sure.
So if we reduce the inflammation anywhere in the colon, it doesn't
Yeah.
necessarily have to be small or large bowel. People may be able to
Tolerate
tolerate
it
dairy better.
Okay, so then the other thing I want to say about lactose is it is an enzymatic function. So there's a
Right.
dysregulation where you don't have the enzyme that breaks up
Right.
the
but
glucose from the lactose.
People can start, if you decrease inflammation because they're being inflamed by casein, which
Right.
is
The
the
enzymes
protein,
might
their
cover
body can
some.
actually, make
Interesting.
more. I know.
But
wild.
the casein is you could have like a casein intolerance or a lactose
outside
intolerance
of-
or both.
Outside of all of that,
Yeah.
casein A1, which is what we are primarily exposed to in the United States, is more inflammatory in most people.
That's
That
why
tracks.
That's why I get sheep's milk yogurt,
Or
which is kind of
A2.
pricey, but good.
A2, you can get it at Costco now.
Yeah.
Oh, you definitely can get, and it's organic.
Yeah.
Oh.
Yeah, sorry.
The-
It's my
Is
happy
my
place.
The
sheep's milk there?
yogurt,
No.
yogurt.
No. I just went yesterday. Nope.
It's in a container with a green label. It's kind of pricey, so
Oh, I know which one you're
could push
talking
me
about.
over the edge for needing a Costco membership if they ever get it.
Yeah.
Anyway, and then goat cheese. I eat goat cheese.
No, Costco has some good
Yeah, they
goat
have
cheese.
Yeah, they
cheese.
do.
Yeah.
Big, giant
Yeah.
goat cheese.
Okay, so anyway, we tried dairy-free just to see it didn't help. Then they had an imaging study, like a follow-up CT abdomen pelvis for an incidentaloma, which are very annoying.
Yeah.
Do you guys know about?
No, tell me about this. I don't know about
Okay,
this.
so someone gets a scan for one thing. They pick up renal cyst. There's this adrenal thing. Their pancreas has the radiologist calls it. It's probably nothing, but if you think it's clinically indicated, you should. They come back with 5 things. It's always defer to PCP. The ER sends us a note. This is a non-urgent finding. Please decide what you want to do. Then I have to send 50 consults to 20 different specialists. The
liability's on you.
Yeah. So then I'm like, what do you want me to do with this? And they're annoyed because I'm sending them consults. And I'm like, well, what do you want me to do? Anyway?
I will say
the one to miss it if it does turn out to be something.
I mean, would definitely not be the one to miss it. I will say it does make me really like my job a little bit more than others.
Go see your PCP.
Okay, don't get a study unless you actually need it. I'm just kidding. I mean,
that's a very good point.
That's the thing, though. Like,
you need it.
Full body PET scans.
I know.
Horrible idea for prevention. Anyone thinking about that?
Well,
do it.
Stuff. Like bodies grow stuff.
If you have a problem, I mean, this person had a problem and they needed it for something else, but then it found something, then you have to get a follow-up scan.
If you're really into fine needle aspirations, don't do those.
Anyway, follow-up CT for this incidentaloma showed a large stool burden. So then when the GIs saw that, they thought this might have been overflow diarrhea and not just the colitis that was acting up.
Can we just stop right there? Because that is so paradoxical. Microscopic colitis means that the large intestine cannot pull out the water, and so everything flows and you have diarrhea. The fact that this patient had a collagenous colitis diagnosis plus a large stool burden, which then it's, they called it overflow. We call it seepage diarrhea, which means that like the walls of the colon are impacted with stool, so you can't pull any water out. So the diarrhea is going through, but that with a microscopic colitis patient,
why do you think that would happen?
Did they say where there was the stool burden?
No. I mean, I could probably have looked. But in the time I'm given to see this person, this is problem number 10.
Yeah, totally.
And so I don't know where it was.
That one took me a little bit for a loop.
Yeah. So I don't know why that was there. Who knows? We don't move as much as we become more experienced often. So I don't know if there was like just, you get more, but it also, it doesn't make sense because they're supposed to be prone to loose stools.
I'm living for this experience right now. This is so, as we become more, I can't wait.
As we become more experienced.
Yeah, this makes me excited.
So they tried the usual, I don't remember if it was, the linaclotide or lubiprostone, one of those, just to see if treating the constipation would help.
So those are osmotic laxatives that are just using different channels to draw water into the stool.
Okay, both of them?
Yeah, both of them. So they're like magnesium citrate or polyethylene glycol.
Yeah.
They just draw water into softened stool. So for someone that already has pretty liquidy stool, it might clear out that chunk in there, but
I think that was their goal.
Have the same symptoms.
Yeah, that was the goal. It had not been working when I saw this person, but they were still kind of in the early days of trying it. So basically, and they had the other typical symptoms of this collagenous colitis: no blood, no pain, weight was fine, just this diarrhea, So anyway, when I saw them, we were just basically waiting to figure out if this new constipation protocol would work. But then afterwards, I was like, what else could be going on here?
Because you're kind of like, do you treat the diarrhea or the constipation?
Yeah.
The diarrhea is their symptom.
Right.
And they're dealing with.
Right.
But it's probably because of constipation.
Or it's possibly because of constipation.
Right.
That's why in this patient, I think the first thing that I would do is to just take a plain film. Let's see if the stool burden. Is the stool burden still present?
Yeah. And
especially
then
after
if it is, maybe load them up with osmotic laxatives, like even a bowel prep or something like that. But only if it's there.
But only if it's there.
You're not going to put them.
Have you guys used a bowel prep I wouldn't use it in, again, more experienced patients, but have you used it in your younger
smaller
patients?
Ones.
Yeah.
You can do liquid magnesium citrate.
That's true. Just buy it at the drugstore.
I mean, I will also say I personally don't love colonics, but this is an example where colonic might be indicated.
Wouldn't you be more worried about C. diff?
I never would do those.
But a colonic?
An experienced patient?
I don't know if I do it with an experienced
patient. In a younger
patient.
person, I feel like it's within your scope to
okay, can we just back up? What are we aging experience? Are we saying 80, 70, 60?
I mean,
I think above 65.
You think geriatric? We define geriatric as about 65.
Let me just remind you.
You're a geriatric
5 months ago, I was also geriatric.
Kind of messed up.
Just your uterus.
No, I'm not. So,
just your uterus was geriatric.
Just bananas.
So anyway, so then, that's a good idea to just see if the person is still constipated or not, just because there's like two conflicting diagnoses.
Yep.
But then afterwards, I was
But
thinking,
also, why did they get
right?
constipation?
I know.
Like, why is the tube slowing down? Is sort of my question.
Yeah.
Maybe sedentary lifestyle.
Yeah.
And like, if that's their lifestyle, how do we prevent this from happening?
Right. So then I was thinking more like once I had a little bit more time to think, like, the person did have type 2 diabetes. It wasn't super well controlled. So there might be
that could be it.
Some things slowing down, working against the colitis.
Nerve damage that happens sometimes with uncontrolled diabetes can impact the bowel.
It could be
motility.
Yeah. And then I was thinking, okay, I was thinking what meds might be contributing,
And your patients generally have a long list of
medications.
Very experienced in medication.
Yes, a lot of medications. And I actually did not know of all the medications that have been linked to microscopic colitis.
I'm excited about this part because before we were chatting, he gave us a little teaser on one,
which isn't which is the one that's more of like, okay, maybe there's an association. It's not like a proven thing.
Okay, what do we have? What's proven?
Okay, first, do you guys know, without looking at my notes, do you know the ones that are most potentially strongly linked?
So I'm going to say NSAIDs.
Yep, NSAIDs.
Are obvious.
Yeah.
To microscopic colitis, PPIs.
Yes, NSAIDs and PPIs. You can look at my notes now.
Okay, great. Thanks.
But basically, so NSAIDs, and I didn't actually recall in my head like all the ways that it impacts bowel function. We know it's not good for the bowel, and we worry about GI bleeds. But also it impairs, do you guys know actually the mechanisms?
The inflammatory mechanism is what I think about.
So it increases intestinal permeability. It impairs intestinal barrier function. It prevents autophagy in the intestinal lining, compromises. It suppresses autophagy, which we want.
Can we talk about that? Can we just define that real quick?
Yeah, getting rid of cell. Isn't it autophagy?
Autophagy. I think it's autophagy, but I don't know. Just say it with confidence and you'll be good. Autophagy is basically the process of your body killing and then recycling old cells because when they're no longer functional, but they're not dead, the body can't reuse all of their substances.
We need to get rid of those old ones.
Yeah.
I just realized we're getting some sunlight hitting in the middle of my face.
You look great. Those of us joining here on joining us.
I'll have this one flash of light.
Portland, Oregon does get sun. Here it is.
And we were not prepared for it. So we'll just kind of move over a little bit here. Okay, so other things, it changes gut microbiota and it affects bile acid. So basically there's all these different mechanisms for NSAIDs causing issues. For PPIs, they think the main way is that it causes, the acid suppression causes dysbiosis, which we
that we know.
I mean, it's cool they're acknowledging that.
Yeah.
Well, this one paper.
No, this is actually open evidence, which looks at all the papers. So I really love that one. It helps my brain when I'm tired. But you apparently can't rely on it. You still have to double check everything. But anyway, okay, it's pretty good.
Because the AI hallucinates. Yep. I love that. That's my favorite.
It does give you all the references. So I don't know how it could be inaccurate, but whatever. Okay, so that's a particularly strong association. I would say PPIs and NSAIDs are the biggest ones. And so if you, and this person was on a PPI. So then I was thinking to try to get them on a H2 blocker at least.
Right. Is there an association with H2 blockers?
So there is an association with ranitidine too, but I didn't find it for famotidine. So
interesting.
Potentially could try that.
I do like.
But then I need time to go through the whole PPI weaning protocol,
which takes a long ass time.
I need a handout. Do you guys have a handout? We need a handout on that.
Ooh, maybe that's something we put on our website if they come visit us. I'm actually sure I have a dot phrase on it.
Please ask them to make it into a nice handout so I can use it for patients. I've just been telling them what we talked about. Like you can open up the capsule, go to like half a capsule a day, go to a cap every other day.
I mean, I get a lot better efficacy layering.
Right. But also the weaning of the PPI is part of the.
Yep. I just go slower than whatever anyone tells you.
Yeah.
I think, especially the internet, go slower than what the internet says.
Okay. And then less sort of like causative, but they've seen some associations was SSRIs, which is not causation. They just found more people who got this diagnosis had been on SSRIs, and they thought it might have been like a bias to just reuse them a lot.
We know that SSRIs function on the neurotransmitters within the GI. I mean, they're literally selective serotonin in the GI up to the brain, and so that makes sense.
SSRIs tend to be more prokinetic than some of like our tricyclic antidepressants.
Yeah.
So I have a question about microscopic colitis. I know that ulcerative colitis and Crohn's are more of a Western society disease. Is microscopic
absolutely?
I mean, we do consume most of the world's drugs, right?
Yeah, and we have like SSRIs in the water at this point, don't we?
Yep.
I mean, we just have a lot of drug
contamination. Yeah, in the water for everyone. I don't know if my water filter filters those out. Anyway.
We both probably could use some SSRIs.
All right. So, and then statins were not implicated, but they said there might be an association. There was not a strong study to support that.
Though, because there
I know.
was a study or is a study on methane positive SIBO being treated by an old school.
Right.
Statin.
The
lovastatin, yeah.
Huh.
And so it actually does not dissolve until it gets in the small bowel.
But it does something to the microbiome.
For sure.
Okay. So statins can alter the gut microbiome as well and affect intestinal barrier function.
For positive or negative effects?
Okay. They said both. They found both. So some of them found that they could increase or decrease Akkermansia, which I think you guys like.
We do like.
Decrease that, but it can increase some other species that are potentially helpful. So
Akkermansia is a keynote species that's in the GI that we know is associated with a lot of other conditions, chronic conditions, including weight, but we don't know.
And PCOS.
And so it's a keystone species. You want it there.
So Akkermansia mucinophilia is its full name, and its last name, mucin. It helps to produce the mucin layer, which is like the architects. What am I trying to say?
Architectural.
Like scaffolding for our mucus that lines it. So if we're low on Akkermansia, we're not going to have a protective barrier like we should. And that's one of the reasons it kind of fades out over time with dysbiosis.
I just imagine now these little bacteria, like cartoon bacteria, scaffolding up mucus. I love that.
Yeah, they're trying. We can help them here. They're trying.
Okay, I've got other things for the statins.
Okay.
They can affect intestinal bile, both the size and composition. It seems like in a negative way. It can inhibit bacterial growth because it has an antimicrobial effect. So I guess that could be good or bad, depending what species it's. One study found it can promote the growth of E. coli and Shigella.
So this is interesting because they just 2 weeks ago changed our guidelines on statin prescribing. We're supposed to start screening at age 30 and basically just give everyone statins.
Why do they even ask us to screen then?
Yeah, I mean, at starting a decade earlier, I'm pretty sure it went from 40 to 30, and they want LDL under 55, 70 or 55 if it's severe.
Wow.
I know. It's really kind of messing with my head now because I used to kind of think more complexly about stuff.
Who came up with the guidelines?
Heart people, the smart heart.
What board are they on?
They want us to do ApoB and lipoprotein a.
Yeah, I mean, that makes sense.
What are their conflicts of interest for the people on the board? Can someone look that up and let us know?
I don't know.
Let me know, because the last person I heard talking about testing everyone for Lp(a) was really excited about the pharmaceutical for which he was consulting that was going to treat it.
I mean, I will say Lp(a), just as a very, very drastic side road that we just took on. Lp(a), I would say they literally call it the widowmaker. Like if you're running an Lp(a), I personally am of the thought where they should be medicated with every class of drugs.
So maybe it's good that we get a pharmaceutical for that one then.
Yeah, I mean that one, if we can get a pharmaceutical, that's the one that kills you.
Okay, take it back. They're probably doing really good work.
I mean,
and they're probably not.
They just are drugs like everything else. They do stuff.
However, if we're going to be a little nuanced about the statin conversation, they have never been shown to prevent primary heart attacks, only secondary. Yes. Yeah. So if I can get a drug that treats Lp(a), I think I would be very pro starting people on it right away as soon as I find a positive Lp(a).
Are you sure?
Primary.
I know that was aspirin. There was that study on aspirin.
Also aspirin.
Okay.
Aspirin's interesting because aspirin has been found to actually prevent or lower the risk of polyp formation from Lynch syndrome patients, which is a genetic, it's a genetic colorectal cancer predisposition.
How does that work?
They don't know, but they know it works.
Wow.
So
they put people on
aspirin is preventative if you have Lynch syndrome.
Crazy.
Everybody should be on aspirin if they have Lynch.
Yeah.
We took a lot of little side roads here. Sorry, guys.
I think so. It sounds like it would probably be good if we got a drug for Lp(a).
Definitely.
I just think that they should clearly, I'm sure they do, the people who will make the guidelines. I wish they were people who weren't connected to the pharmaceuticals that we're going to use to treat the condition.
Here is the problem.
Should be USPSTF.
Here's what I'm going to say about that. It's very difficult because the people who write the consensus statements or the guidelines are the people who are at the top of their field. Yeah. And the pharmaceutical industry is really good at picking up and paying very well.
There's got to be people in academics who aren't consulting who are equally good. No? You don't think so?
I mean, I think it's easier to find people who are paid.
They also have platforms.
Yeah.
You know. They're targeted.
It just doesn't make sense to me. We have to fill out all these conflicts of interest things. Okay. Anyway, off of our tangent here.
So this patient tried mesalamine or no?
No, they did not try mesalamine. The other things that have been seen to potentially help for refractory microscopic colitis, I was surprised to actually see bismuth in there. So if budesonide doesn't work, which apparently there's relapse is quite frequent after stopping budesonide.
It's a bummer.
So you have most people on it indefinitely?
No, absolutely not. You do not have
off of.
You cannot stay on budesonide indefinitely. It will cause bone deterioration and steroid side effects. Just 15% less.
No, but how long can you keep them on it?
I usually go 3 months. I don't go longer than 3 months.
And then what if it comes back and nothing's working? Do you repeat a course?
Okay, so there are 4 steps of treatment, right? First step is always budesonide, which makes good sense. I even tell my naturopathic patients to start it because if it works, and it usually works, great. But if it doesn't work or it becomes refractory, then we move on to bismuths. Then we also move on to bile sequestering agents like cholestyramine or cholesterol. And then we move on to mesalamine. And then we move on to biologics, which is new in the last couple of years. They're just starting to treat microscopic colitis with biologics.
Okay. Yeah, basically you outlined the research.
But, great. It's almost like I studied it before.
So basically, I was just surprised that they said 70% of people relapse after discontinuing the budesonide. So they did say you can do low-dose maintenance therapy with budesonide more long-term. I agree. It's not a good idea. Anyway.
So I had a patient who, similar demographic, who had very low ferritin, and we corrected the ferritin and her diarrhea went away.
Which that kind of makes sense to me because the ferritin is there to rebuild the cells of the colonocytes.
So I'm also wondering in this advanced or experienced population, just basic stuff like looking at nutrient deficiencies so that body can try to heal inflammation.
Or maybe just ordering a multivitamin mineral and checking iron and B12.
Yeah, vitamin D, like the basics you need to kind of help support your body and heal.
Seeing a nutritionist.
I often think of this population as dysbiosis being part of the core. And so this is a place where I do feel like some of our stool testing would be useful. Even some of our small bowel testing would be useful. And then I use ozone pretty successfully in this population.
With microscopic colitis.
Yeah.
You just dose it kind of high to get it everywhere.
I'm in 250 cc's. That's my usual protocol. 250 cc's at right around 4 to 40 nanograms per deciliter.
And how are you monitoring? Just symptoms?
I'm just monitoring by symptoms.
Interesting.
Yeah, there's no reliable way to monitor besides how they're doing.
Yeah.
But I mean, these people know how they're doing.
Yeah.
It's not IBD. Like you don't have a silent microscopic colitis. You're having diarrhea.
Yeah.
So you maybe treat with budesonide initially, try to get them off after that initial course, and then check all these other things while you have some time. I don't think I didn't mean long-term regular dosing, but they were saying 3 milligrams, maybe even every other day, if nothing else is working, was one of the options. But you're right. I think then they moved to the biologics
but these
and
are also
bismuth.
The folks at risk for osteoporosis.
Yeah, no, it's not it's not ideal. I think it was for like if nothing's working kind of thing.
Also, the other piece of that is you have to go back because these people have dysbiosis. So this could cause a fungal overgrowth.
Yeah.
Chronic steroids will cause fungal. The budesonide. Yeah. Chronic steroids will cause fungal overgrowth.
That stinks.
I also wonder, because we don't want to keep people on bismuth long term, especially Pepto-Bismol, the version compounded bismuth, versus something like loperamide to help manage the diarrhea.
Yeah, loperamide will have efficacy and then stop having efficacy.
Totally. But if
is there a dependence issue or something, or why does it stop working?
I think that the body gets
used to it.
Yeah, what's the word I'm looking for? Yeah, tolerance. Yeah.
Okay. Well. Yeah, then there's the biologic. So I wish they would come out with a probiotic that worked reliably for fungal stuff so that we could, none of them work that I've just tried with people based on the
fungal stuff.
Just like something easy that works in the GI tract.
Yeah, it's
none of the ones that are supposed to do any help with that actually seem to do anything.
So cholestyramine, how often do you see that work?
Actually, quite a bit.
Yeah,
that is
great for diarrhea.
That's what it said for kind of milder cases to consider the cholestyramine cholesterol, but maybe you could also use that as a step down therapy.
I will also say that I feel like, historically speaking, with patients, the cholestyramine or the powders work better than the tablets.
They do, because you have to break them down.
Yeah,
it's just the powder's just gross.
Yeah, the powder is gross. It's like orange chalk, but it is. It's probably for mild to moderate cases. It's pretty reliable.
I've heard if you mix it with mango juice,
juice
kind of takes the edge off
because it's like a mucilaginous juice.
Like tropical fruit. Yeah.
Pineapple juice, mango juice.
Trader Joe's.
We used to have this thing when we were kids from India. It's like a mango puree with sugar with the fried bread. It was very delicious.
Wow.
I would like to go to India with Ami. I'm making it public on the podcast as if I haven't made it private.
We're manifesting.
Okay, so I think your resident, if they could also make a handout on general treatment like categories for microscopic colitis, that would be great because you still have to do all these things.
Who can make
hard
handouts?
To remember.
Open Evidence will make you patient handouts.
Okay, well, but we need someone to remember to do it. Put it on the website.
We need someone to review it.
But I'm saying because this is a whole thing. Okay, you have this diagnosis. here's what we do now. These are all the other things we need to think about in the interim. Like, do you have meds that are contributing?
Yes.
Can we get you off of those? How do we get you off of those? What other things can we add to help you with those symptoms? Do you have dysbiosis? How do we address that? Do you have nutritional deficiency? I mean, we need a whole outline.
Yeah, I mean, here's the thing.
At least to remember the categories.
It's complicated. Again. We're just going to play it on repeat for ourselves.
I'm still asking for handouts from the residents.
From my residents.
Post them on the website so I can download them when I forget what I need to do.
Shout out to the lovely residents.
Do you guys get bismuth compounded then?
So there is a compounded bismuth. That's bismuth subnitrate.
Yeah. Okay, this says subsalicylate.
There also is no.
But if you don't want all the stuff in it.
Okay, wait. There is a new bismuth subsalicylate. No, subsalicylate. There's a bismuth subsalicylate that is free of all preservatives and additive. It's available on Amazon and it's completely additive free.
Is it at drugstores and stuff?
There's a lot of people.
All right, but the studies
have the other stuff.
It doesn't have the dyes.
Dose that daily
for
salicylate,
a lot of people have sensitivities to those.
To salicylates.
Yeah. And it's not dissimilar.
But the problem is all the data is on the bismuth subsalicylate.
And we think that's working because it's anti-inflammatory, antimicrobial.
It's antimicrobial, anti-inflammatory, it's like protective. It protects the GI.
Because it said that had that had better results than the budesonide.
Don't you think compounded works too?
Yeah, yes, it's a little bit expensive. Yeah. The problem with compounded, the problem with bismuth is it is very, very safe until it is not safe. Short term.
It depletes minerals.
Exactly.
So people, you have to take breaks on
And it could be kidney toxic. Yeah. It could be liver toxic.
Even for a couple weeks?
No, 6 weeks. Studies on very, very high doses.
So that's why they want budesonide first. Yeah. That's why, because they were giving results that were similar with less relapse. So I was trying to figure out why, but I guess it's because of these other toxicities. Even if we're using it as short term, you still want to use budesonide first.
Very, very safe. 2,000 milligrams of bismuth daily in divided doses for 6 weeks. Completely safe. No adverse effects.
Maybe check kidney function and or liver function if you're worried, like we do with antiviral, antifungals.
No study has ever gone longer than 6 weeks.
Okay. So
I would also consider mineral repletion.
Always,
you just have to take it at the opposite time of bismuth.
Yeah.
Okay.
Or in between.
So I guess those are the reasons that most people, all of the official organizations recommend budesonide first. I was just surprised at the high efficacy compared to budesonide, and it's old and cheap. I was just wondering, why.
That's an interesting case.
Yeah,
and it's a case in progress. I can't wait to hear the next step. Do they still have bowel overload?
Yeah, I want that X-ray, and I want to know where the stool is. Can you read?
Why?
If it's ascending colon, it's totally different than descending colon.
Are you going to do your abdominal manipulation technique then? Or?
Sure.
Then what else are you
I
going to do?
find that ascending constipation is much harder to treat.
Yes.
Because you shouldn't have dried out stool there.
Because of an anatomical issue, usually, that it gets stuck there?
Adhesions can cause adhesions, like endometriosis, or people have had their appendix out, but it should be like slushy material there.
So what are you going to do then for that?
I would probably lean more on physical medicine.
Okay. And you know what to do for that.
But I'd also really consider motility disorders.
Yeah.
Oh,
why
totally.
is it stalling, in that part of the colon? Like at the other end, that makes sense. It's where everyone gets constipated. But
we might need an entire episode on this.
Yeah. Well,
because I've never. Okay. This was a great episode. Thanks, Dr. Kapadia.
Thanks, Dr. Kapadia. Welcome back.
Thanks, Turds. Thanks for joining us today. Stay tuned. We release episodes every 2 weeks.
If you like this episode, please subscribe and don't forget to rate and review us to help spread the turd nerd word.